nutrition support dietitian at Bunjangcha Medical Center. My topic is nutritional intervention in patients under continuous renal replacement therapy. My content consists of 3 parts. Firstly, I will discuss case received continuous renal replacement therapy. The patient was hospitalized with dyspnea as the chief complaint. The diagnosis was mitral stenosis and coronary angiography was performed on the second day of hospitalization. The patient received the replacement of artificial valve on the 8th of day admission. The patient suffered cardiac arrest 2 days after operation and was transferred to the ICU. After entering the ICU, there was almost no urine output and creatinine was rising, so CRRT was started. Mode was continuous venous hemodiafiltration, anticoagulation, dialysate, and replacement fluid were injected. She was also receiving ventilator care. The patient ate diabetes meals in the ward for about 9 days after admission. Tube feeding was started on the second day of ICU. The patient was referred to nutrition support team on day 4th of ICU admission. At the time of referral, the patient's height and weight were 142 centimeters per 59 kg and BMI 29. Whole body edema and abdominal distension were observed during clinical assessment. Energy and protein were supplied at 56% and 37% of the requirement respectively. Energy and protein requirements were calculated at 1,200 kilocalories and 80 grams respectively. Although BMI was 29 when determining nutrition assessment, it was assessed as mild malnutrition, considering whole body edema and low energy intake rate. Nutritional intake for 20 days in ICU. Blue is enteral nutrition, red is parenteral nutrition, and green is additional calories through dialysate. Parenteral nutrition was started initially and then discontinued. The supply of enteral nutrition has been continuously increased. In the case of calorie supply rate through dialysate, the calorie contribution rate was high at the beginning. In the contribution rate decreased as the dialysate was changed on the 8th day of ICU. Protein was supplied by enteral nutrition, considering the amount of protein loss through CRRT. It was supplied as a high protein formula, and the protein was also satisfied after the target energy supply. This patient had little urine output fluid. The mean of the input and output fluid balance was about 300 cc, which was consistently confirmed as a positive balance. The initial BMI for ICU admission was 29, but it was edema status. BMI was 26 with a steady decrease over 20 days of ICU, but it was still edema status. Albumin is the most frequently used nutritional biomarker. It decreased from 3.9 at the beginning of ICU admission to 2.6 after 20 days of continuous CRRT. On day 10 of admission, she was transferred to the ICU and received CRRT and ventilator care. Tube feeding was started after moving to the ICU. The energy requirement was 1,200 kilocalories and the protein requirement was 80 grams. BMI and albumin continued to decrease despite the supply of high protein formula. It may be obese sarcopenia. The following contains are nutritional considerations for CRRT. When the hemodynamic instability of acute kidney injury in the ICU patient is found, CRRT is considered. These considerations can be classified according to 5 major contents. The first consideration is energy. In the largest multi-center study of AKI treatment with CRRT to date, the average mean daily calorie intake was low at 11 kilocalories per kilogram per day. However, patients with a lower mean DCI had similar mortality and those with a higher DCI. And non-survivors had a similar than DCI to survivors. Conventional predictive formulas may frequently lead to incorrect energy need estimation. In critically ill patients with AKI and increased risk for under or overfeeding, it's likely when energy needs are estimated instead of measured. Blend-Altman analysis was used for a visual appraisal of agreements between predictive equations and indirect calorimetry. The wide range of agreements in each case highlight the potential for under or overfeeding. According to ISPAN, indirect calorimetry can be performed during CRRT. If indirect calorimetry is used, isocaloric nutrition rather than hypocaloric nutrition can be implemented. If predictive equations are used to estimate the energy need, hypocaloric nutrition should be preferred over isocaloric nutrition. The second topic is additional calories. CRRT group received significantly higher mean overall non-nutritive calorie energy on all days as detailed as in figure. Patients who are critically ill and receiving additional NNCs may be at risk of overfeeding. This implies a need for greater emphasis on delivering and monitoring medical nutrition therapy for patients receiving CRRT. For individual non-nutritive calories, analysis of mean daily energy is shown in figure. Compared with the non-CRRT group, the CRRT group received significantly higher energy from dextrose on day 3 and lower energy from propofol on day 1. Daily, patients on CRRT could receive an additional 100 kilocalories from citrate. In 2021, ISPAN recommended that glucose from dialysis hemofiltration solutions should be included in the calculation to determine the total daily energy. The lactate load may correspond to a calorie intake of up to 500 kilocalories, which should be considered when calculating the energy requirement. Citrate solutions are another important source. In the case of Korea, the use of citrated anticoagulation has not yet been approved. The third one is protein. This prospective observational study in critically ill patients demonstrates that the median total amino acid loss was 13 grams. This study implicates that amino acid loss is considerable and may contribute to a negative protein balance. Of the 70 critically ill patients requiring CRRT, 27 patients survived on day 28. The dietary protein intake and serum albumin of survivors was significantly higher than non-survivors. SCCM and ASPEN suggests that patients receiving CRRT receive increased protein up to a maximum of 2.5 grams per kilogram per day. In 2021, ISPAN guidelines recommended that critically ill patients may be prescribed 1.5 grams per kilogram per day, up to 1.7 grams per kilogram per day. Kidney replacement therapy can exert a negative influence on protein balance by inducing amino acid and peptide per protein losses. Protein requirement can be increased in patients undergoing KRT. The fourth is micronutrients. In a prospective randomized crossover trial, CRRT resulted in significant losses and negative balances of zinc, selenium, copper, and thiamine, which contributed to low plasma concentrations. This shows micronutrient losses and recommended supplementation in CRRT. High recommendations are recommended, taking into account high losses for thiamine, folate, vitamin C, zinc, selenium, and copper. In patients on CRRT, a reduction in serum levels of thiamine, folate, and vitamin C have been described, probably as a consequence of increased utilization in critical illness and losses secondary to CRRT. But in critically ill patients with AKI, serum concentrations of important nutrients were commonly below the reference rate independent of treatment with CRRT. In 2021, ISPAN guidelines recommended that for CRRT, trace elements should be monitored and supplemented, especially selenium, zinc, and copper. Also, ISPAN recommends special attention should be given to vitamin C, folate, and thiamine. This is Korean and global enteral formula for CRRT patients. The biggest feature is the high protein component. The content of zinc, selenium, and copper, as well as thiamine, folate, and vitamin C should be carefully checked and selected. The last consideration is monitoring. The monitoring of nutritional status recommended to check 3 types. These are weight change, biochemical data, and CRRT methods. Rapid weight change is likely to reflect fluid balance more than nutritional status. Glucose control is important, and the serum triglycerides should be monitored if intravenous lipids are administered. Mode of CRRT that use convection show higher protein losses in the front when compared to those using diffusion. Nutritional parameters should be frequently reassessed, carefully integrated with CRRT. The composition of commercial CRRT fluids varies. Phosphorus is not a standard component of replacement or dialysate fluids. However, phosphate-containing fluids are available. Traditional CRRT fluids contain dextrose, but not amino acid and vitamins. In 2021, ISPEN guidelines recommended that patients with AKI should maintain between 140 to 180 in serum glucose levels. Electrolyte abnormalities are common in patients with AKI receiving KRT and shall be closely monitored. Conclusion. This is a process for AKI that can be considered when selecting EM formula. If there isn't electrolyte imbalance, standard formula can be considered. If there is electrolyte imbalance and the patient requires CRRT, high protein formula may be considered. If the patient doesn't require CRRT, renal disorder formula can be considered. Medical nutrition therapy for renal disorders varies depending on how kidney disease is treated and the level of disease. The protein content varies according to the cause of renal disease. So, low amounts of sodium, potassium, phosphate, and calcium are recommended. However, during CRRT, it is recommended to observe a sufficient amount of protein and to monitor closely rather than strictly restricting nutrients. In conclusion, high protein formula is recommended during CRRT, but each case has a different underlying disease or condition. An individualized approach to nutritional support is recommended. The most important thing is communicated with the nutrition support team and nephrology. Thank you.
Comprehensive introduction about the nutrition concerns for the patients on the continuous renal therapy. If there is any questions from the floor, we'll take one or two.
한국어로 대답하겠습니다.
Okay, many patients receiving this continuous renal replacement therapy experience the acute kidney injury because of the sepsis, and they are also receiving antibiotic treatment. So we experience very many times of diarrhea associated with antibiotics itself and enteral nutrition. So we frequently prescribe the enteral form of nutrition or nutrition form of for the enteral protection, right? 위장관 경화지. So I'm curious about the difference of micronutrients and protein content of enteral form. I mean that specific enteral form and the usual form of the nutrients. Did you understand my question? Okay. The difference of micronutrient and the protein content of the specific formula for diarrhea and the usual form.
예, 제가 한국어로 답하겠습니다. 게 이제 많은 5개 회사의 그 엔테랄 포뮬라가 있습니다. 예, 그 중에서 이제 CRRT 때는 하이 프로틴 포뮬라를 이제 사용하라고 레커멘드하고 있고 이제 볼륨 제한은 필요 없습니다. 그래서 프로틴 같은 경우 이제 CPF 비율상 25% 정도 높은 것을 사용을 하고 아까 얘기한 뭐 sepsis일 때 뭐 이제 어떤 특정 아미노산이 더 좋다는 연구 결과는 아직 언노운 상태이기 때문에 그냥 프로틴의 비율을 높은 것을 사용하고 있습니다. 그리고 추가적으로 마이크로 뉴트리언트가 많이 이제 CRRT 상황에서 손실이 되기 때문에 이제 가급적이면 하이 프로틴 포뮬라 중에서 마이크로 뉴트리언트가 높은 것들을 이제 사용하는 것을 레커멘드 하고 있습니다. 네.
감사합니다. Thank you very much.